I'd like you to turn to a person that you're next to. Please turn to them. Look them in the eyes. Okay, and that's why I wanted you to be with somebody. Move around. There's somebody over there that doesn't have a partner. Make sure you're making eye contact. No, this poor woman over here needs you. Over there. I want you to look at them, and I want you to say, I see you. What does that mean? And if you feel like it and want to hug them, you can, or shake their hand. But what does it mean to say, I see you? It doesn't matter if the challenges are invisible. What you're saying is you're important. I see you. My phone is not on. I'm looking you in the eyes. That's what you need to do today with this movie. Listen to the stories. See what they're saying. Hear what they're saying. And see what you can do to be part of helping people with challenges, live life to its fullest. So I'm going to introduce Rivka now. It was a pleasure getting to know her. I only had 2 minutes, so I think I kept within my timeline. And I want to hand Rivka a pair of pink socks, because how I learned about I See You is part of the Pink Socks initiative that was started, that's going around the world, and people are handing each other pink socks so that they can see each other. So next time I see Rivka, she'll be wearing her pink socks. Thank you so much for joining us tonight.
Thank you. Hi, welcome everybody. First, I want to thank Karen Jacobs for that wonderful introduction and for being here and giving and offering opening remarks. Before I tell you a little bit about me and give you a context for tonight's program, I also want to thank the Sargent College Alumni Association and Lauren Tamburello for hosting this event and for helping us to organize it. And I also want to thank Pat Woods, who is a co-organizer of the event. Is Pat here? And she can wave her hand. She's probably outside organizing. There's Pat in the back. Yay, thank you, Pat. I also want to acknowledge the support of a grant from the Social Arts Council, which helped us to hold this event. And, we should have advanced the slide one, sorry about that. And then I was going to go back one slide, but I don't have to. That is our list of event co-sponsors. And in particular, I want to thank the American Physical Therapy Association of Massachusetts. Is anybody here a physical therapist by chance? Excellent. Thank you for coming. So I'm Rivka Solomon. I'm with the Massachusetts ME/CFS and FM Association. That stands for Myalgic Encephalomyelitis / Chronic Fatigue Syndrome and Fibromyalgia Association. As you will hear tonight as the evening progresses, many of us will be calling the disease ME, myalgic encephalomyelitis, because we feel that CFS, or chronic fatigue syndrome, does not describe the devastation of this disease. So many of us eschew that name and call it ME. I have been sick with ME for 28 long years, and I have a doctor in the audience who can attest to that. I saw her in early 80s, and it's been a really rough ride. Many of us with this disease, as you'll hear tonight, will end up homebound and bedridden a lot. And I have spent much of the past 28 years unable to function, very weak, and thus bedridden and homebound. So this was the slide that was supposed to be on before, and it is on now. We were going to have opening remarks from Karen Jacobs, and then me giving a little bit of an overview and some context for ME. And then we're going to see part one of the film, and that's only 23 minutes, so it's basically a teaser. And then we're doing something unique this time. We're going to interrupt the film and have the panel discussion at that time, and we're so grateful to have moderator Dr. Kimberly Sullivan from the Gulf War Illness Consortium and the BU School of Public Health. And then the panel is going to include a doctor in the Boston area who treats ME, a neuroscientist / researcher from Mass General Hospital and Harvard, and a caregiver for somebody with ME/CFS. So, next slide. So, for the past 30 years, ME has not been getting much attention and has not been taken as seriously as the disease is. It has not been given the respect that a serious disease deserves. And then, in 2015, something shifted. The NIH commissioned the Institute of Medicine, IOM, to research the disease, and they came out with a report. And thank goodness for that, because that's changed the game for us. They essentially said, this is a summary of the bullets that you see above. They said, this is a serious disease. Bullet number 2, it's not being taught in medical schools. About a third of medical schools teach about ME, and the information that they teach is not always correct. Number 3, healthcare providers often will dismiss patients with this disease. In fact, they will even act hostile towards patients in that they tell them, get on with your life, it's all in your head, exercise your way through this. We will hear more about the detrimental effects of exercising for a group of patients that have an energy production impairment in a minute. And part of what has brought this situation about, this universal dismissal of a very serious disease, is that there is remarkably little research funding coming from the NIH, the National Institutes of Health, going towards ME. And this Institute of Medicine report said funding is urgently needed. Oops, sorry. Some key facts. It's a multi-system disease that includes neurological abnormalities and an energy production impairment so severe that merely brushing your teeth or speaking on the phone can be more than your body can actually handle. There's an estimated 1 to 2.5 million of us in the country. 75% of us are women. 70% can't work. 25% are homebound and bedridden. No diagnostic test, no FDA-approved treatments, no cure. Symptoms can persist for years, and in fact, recovery is rare. Up to 91% of people with this disease are not even diagnosed, or they're misdiagnosed. There's fewer than a dozen medical specialists available in the entire country, so that's for up to 2.5 million of us, there's about a dozen medical specialists in the country, which is why we all have to wait so long to see them and often travel very far to see them. And some of us can't travel, of course. We're too sick. ME costs the economy $17 to $24 billion annually, and yet NIH funding, as you can see, it's that last little sliver at the end of the chart. NIH funding is so low over the past 30 years, it's been about $5 to $6 million a year. And if you know anything about Washington, D.C., $5 to $6 million is like an insult. It's nothing. It's peanuts. It's peanut shells. The good news is that last year NIH bumped this up to $13 million a year, but still that's considered nothing in the world of Washington, D.C. Next slide. Who we are. We are the Massachusetts ME/CFS and FM Association. We are an advocacy group in Massachusetts. We focus on education, patient support, and advocacy. Very exciting. In the absence of NIH funding and support, we have turned to Congress. And we got universal support from our members of Congress. The entire Massachusetts congressional delegation signed a joint statement of support saying that they would help us push for funding and recognition. And yes, it's very, very exciting. And Senator Markey introduced a Senate resolution for ME, which is also very exciting. And of course, Senator Warren co-sponsored that, as did Senator Susan Collins, Republican from Maine. So now we are going to see the first 23 minutes of Unrest. It's a film that's literally changing the landscape for those of us with this disease. It was shortlisted for an Oscar. It won a Sundance Film Festival Award, Boston Globe Film Festival Award. It's been featured in countless newspapers and magazines, and it's available on Netflix for free, and I am going to stop there. So we can see the first 23 minutes of the film, and then we'll be having the panel discussion. ME/CFS is an acquired chronic multi-system disease characterized by significant relapse, after physical, cognitive, and emotional exertion of any sort. And you saw that happen right there. And for me personally, when I go home, I look fine now, but when I go home, we don't know what the end result will be. Will I be in bed and unable to walk literally to the bathroom for days, weeks, months? That's what happened for the last event that I helped to lead in May. I was pretty much stuck in bed or near bed for the next couple of months. The disease causes immune, neurological, energy, metabolism, and cognitive impairment, sleep abnormalities, autonomic dysfunction, resulting in significant functional impairment accompanied by pathological levels of fatigue, not your average fatigue. The cause of the disease remains unknown, although in many cases, symptoms may have been triggered by an infection such as mine. I got mononucleosis, and I essentially never got better, and about a third of people with ME, it started with mono. The two big takeaways that I want you to hold on to as you leave is that this is not a psychological psychiatric disease, and it is not just fatigue. We have a clinical diagnostic criteria from the Institute of Medicine report. I won't go into great detail, but the core criteria is impaired function accompanied by fatigue that persists for longer than 6 months. We also have what's called post-exertional malaise, or what patients often will call post-exertional collapse. And that's after physical or mental activities, there will be a delayed exacerbation of symptoms and reduction of functioning, and that can be quite severe. So the last event that I helped to present at, I ended up for the next 2 months stuck in or near bed. We also have non-restorative sleep. We wake up feeling like we hadn't slept at all. For me, this has been going on for 28 years. And often people will have cognitive impairment or orthostatic intolerance. There's a host of other symptoms. I won't go into detail, but chronic pain, chronic infections, neuroendocrine manifestations, gastrointestinal manifestations, and you saw with Jessica that she had light and sound sensitivities. So this is a nice colorful slide that basically says the same thing I just said. We have problems all throughout the body. It's a multi-systemic disease. It impacts the HPA axis, the immune system, the autonomic nervous system, cardiovascular system, central nervous system, and all that colludes and comes together and brings with it an energy production impairment and cognitive impairment and sleep impairments. Basic clinical management is what you would expect, which is that you want to always validate the patient's experience and educate both yourself and the patient about the disease. Then you need to assess support needs. So does the patient have shelter, literally? Do they have food? How are they doing at school, at work? Do they need disability to get on disability, or do they need assistive devices? Do they need caregivers? A lot of us can't do basic things like wash dishes or take showers without caregivers. You want to educate yourself and the patient about pacing to minimize post-exertional malaise or post-exertional collapse. And what that means is that the patient needs to learn how to stay within an energy envelope. What is the physical and cognitive line that they cannot cross? What activities can they not do? So that they will stay within their energy envelope and not have a collapse or a PEM. And importantly, I want to make note of the fact that the Centers for Disease Control, the CDC, no longer recommends two therapies that they have been recommending for decades. One is cognitive behavior therapy, and the other is graded exercise therapy. Both of these therapies can cause harm by encouraging patients to push past their energy limits, especially telling a patient to exercise who has an energy production impairment is not unlike telling a diabetic to eat sugar. It is the wrong thing to do. Obviously, you want to manage the symptoms that you can treat. Is there sleep med that would help the patient to sleep? Are there orthostatic intolerance meds such as mine? I'm on a beta blocker. Are there ways that you can address the pain or the GI issues? And obviously you want to treat the comorbidities such as fibromyalgia, sleep disorders, POTS, which is postural tachycardia syndrome, and a whole host of other things. I do want to say something about secondary depression, which is that most of us are not depressed, but what happens is when you lose everything in your life and you become bedridden and homebound for decades on end, you can obviously you can get depressed. So if you can treat those. And some doctors have found help treating patients with immune modulators or antivirals, such as myself. And with that, before I introduce the panel moderator, I just want to say that there are a few of us who are living with this disease, and so I would welcome the panel or the panel moderator to, feel free to bunt any questions to us if you want to. We do have a BU professor who's here, and she struggles with the disease, and we also have a retired child psychiatrist who also is living with the disease, who is also here. And with that, I will introduce the panel moderator, Kimberly Sullivan. Dr. Sullivan is a research assistant professor of environmental health at Boston University School of Public Health and a former associate scientific director for the congressionally directed Research Advisory Committee on Gulf War Veterans Illness. We're so thrilled to have her because a lot of ME ends up presenting clinically very similar to Gulf War illness. So Dr. Sullivan is a behavioral neuroscientist who obtained her Ph.D. from BU. Yay, BU. She has been consistently funded to study Gulf War illness since the mid-1990s and is currently principal investigator on the Gulf War Illness Consortium study, and that includes 9 study sites around the country. So we feel very, very lucky to have Dr. Sullivan. Dr. Sullivan. And I'm going to hand it over to you.
All right, so start here, then we can go to the panel.
Yeah.
Can we get the panelists to come up? Okay, great. Perfect, great. All right. Great, well, thank you all for coming. Thank you for that nice introduction. Yes, I've worked with Gulf War veterans for many years, and a lot of them do have ME/CFS as well. So this is a disorder that our veterans suffer with in addition. And so we'll get going with the panel. Our first panelist is Bob Robitaille. He's an advocate with the Massachusetts ME/CFS and Fibromyalgia Association, where he coordinates the work with elected officials in the Mass State House and Congress. He's also a caregiver of an adult daughter living with ME/CFS who's been sick for 15 years. Thank you for coming, Bob, and I know that your daughter's not able to make it today. Do you want to start by telling us how the situation with your family has been dealing with ME/CFS?
Turn the mic on. Can everybody hear me? So first of all, thanks for taking time out of your busy schedules to come to this event tonight. As a caregiver and my daughter's a patient, I'll get into that a little bit. It's really important to us to get the word out, and we thank you for coming. My name is Bob Robitaille. As Kim mentioned, my wife Kathy is in the audience. We're both members of Mass ME. We changed the name from CFIDS to ME. And we both are volunteers. As Kim mentioned, I'm working on the congressional aspect of it, and my wife is the patient services person. So our daughter is 42 years old. Her name is Roby. There she is. Okay. So she's 42 years old, and she is also a member volunteer of this organization when she is capable of being, working on different issues. Unfortunately, she made a tough decision yesterday, deciding she couldn't attend today, and it really broke her heart not to be able to attend because she wanted to really, really be here. So anyway, that's why I brought the picture, so you can see what she looks like. So she's been involved a lot with the peer support group, both as a leader and as a member of that group. The group is 3 young people with ME. She's the oldest, actually, and then we have a 30-year-old who's had it since he was 13, and then I forget how old Rachel is, but anyway, the bottom line is that those 3, along with Phil Sherman, who's one of our older folks in the organization, they're working on a platform that they're working with ME Action, which is a West Coast-based organization, to be able to replicate this peer group, across the country in different states. So it's taken a lot of her time. When she, like I said, when she can operate that, she does well. Let's see. So I'm going to read her statement in a minute. But before then, I'd just like to say that 17 years ago, Roby, she was a vibrant young woman in her 20s with a great future ahead of her. She is now an image of her former self. After moving back to Massachusetts of March of last year to seek proper medical attention, we were sort of shocked after she got back here and she started seeing some doctors that the treatment of some inflicted with this disease was no better than here than being in the state of Texas out in the country with a country doctor. But that said, thanks to people like Michael, who you'll hear from shortly, we have dedicated researchers who are needed to find the answers to solve this problem. Of course, progress is being made, but slowly, and as Rivka alluded to earlier, the funding is really, really low, and we need to step that up significantly. So Roby's life has changed dramatically, and as caregivers, so has ours, my wife and I. And for the three of us, there is no end in sight, which is troubling at our age. You never know what 10 or 15 years is going to be like for her, especially if we're not around. So millions of families around the world are in the same boat that we all are. And the only thing we can do is hope for the future. So now I'm going to read her message that she put together yesterday and was hoping to be here. So my name is Roby. I'm a 42-year-old woman and have had ME for 16 years. Before I became ill with ME, I was a very active person. I was able to exercise, often held 2 jobs, had a busy social life, enjoyed doing artwork and photography, and I loved reading books. Many people with ME get sick with a virus and never recover. My onset was different. When I was 25, I experienced a few potential precursors to ME, including a tick bite and head trauma. By age 26, I felt unwell and unusually exhausted, but my doctor dismissed me and told me that I was the epitome of perfect health. For the first decade living with ME, I had a mild case, even though I felt like I was moving through mud and always exhausted. I was able to work and care for myself. However, most of my time outside of work was spent resting home alone on my couch. Hardly the life I envisioned for myself. My health slowly deteriorated for 12 years before I was finally diagnosed with ME in 2014. And by the way, that was in Texas, and she self-diagnosed herself by doing a lot of research. And she finally gave it to the doctor. He did his research on it, and he agreed that that's probably what she had. The year before I was diagnosed, I proudly enrolled in a graduate program for counseling psychology. I did not know that studying and writing research papers was making me more sick. By the second year, I found it so hard to function that I did nothing but rest and take 1 class per semester. My cognitive impairment, which is often referred to as brain fog, became so bad that I eventually lost the ability to read. With only a few classes left to go, I had no choice but to drop out of school. I was devastated. And by the way, she had 1.5 classes to go, and she had a 4.0 average at Texas A&M University, and to this date, she has not completed that degree. I was living alone in Texas and stuck in bed most of the day, unable to work, finding it incredibly difficult to shop for food and cook for myself. In March of 2007, with my parents' help, I gave away most of my belongings and moved to their home in Rentham, Massachusetts. Now I spend about 23 hours a day in bed. I am unable to read more than a few paragraphs at a time. My entire system is compromised. My brain process is slow, and every movement takes effort. Every physical and mental function, including watching TV, preparing this letter for you, and messaging or talking over the phone with friends, taxes my system and makes my condition worse. I am only able to leave the house about once a month now. I am very sad that I was unable to share this event with you today. I am waiting for a medical treatment, so like many of us in what feels purgatory. As bad as I've had it, I still feel like one of the lucky ones who can function and communicate. My condition is considered moderate ME. I thank you from all ME patients, mild to severe, for taking the time to learn about ME. Your interest in and acknowledgement of this disease reminds us and our caregivers that we are still part of this society, and gives me hope that we will one day be back out in the real world with you. And that was her statement. Kim.
Thank you, Bob, for sharing that
Thank
story of your family and your daughter's health. We're fortunate to have a physician who's been treating patients with ME/CFS for many years, Jeanne Hubbuch. Jean's a Boston area physician who's been working for 30 years with people with ME/CFS, fibromyalgia, and Lyme disease. She's a board certified in family practice and environmental medicine, and her interest in health with her work, her interest in health began with her work with women's self-help health movement. That's a tongue twister, Jeanne. Welcome, and thank you for coming today. A couple of questions for you. What's it like being a doctor in this field treating patients with ME/CFS?
Okay, is this on? Yes? Okay. Well, really what it is you're looking at chronically ill people and trying to sort through the whole story that someone comes and lays at your feet and trying to figure out what pieces of it can you do something about to make someone's life better. So I find that incredibly challenging and rewarding to be able to work with people over years. And so even the people that haven't really recovered, like the examples that you've just heard about, those of us in the field can still do some things to help alleviate some of the symptoms. Like, for example, some people have real viral component, and sometimes either antiviral medications or herbals can help. People with the autonomic dysregulation, the postural hypotension and tachycardia can be really helped by the medications that are available standardly. And sometimes those can make a big difference. The other part that I think is so crucial is that people feel like they've been heard and that somebody cares about them and that someone is watching out for progression or some other illness to appear, which obviously could in a chronic fatigue ME person. So that's really where I see my role. And after I'd been treating ME, chronic fatigue, fibromyalgia for a number of years, we came to realize that some of the people who I was labeling that way actually had Lyme and co-infections. So that brought in a whole other area of exploration and of trying to understand what those difficult infections are about and how to go about trying to treat them.
Thank you for that. I think you've hit on a very interesting point of just validating that there's an illness here. I think it's such an important thing, and I've seen that many, many times with my Gulf War veterans who are dealing with Gulf War illness as well, and sometimes ME/CFS and fibromyalgia on top of that. So I think that's a very, very important thing that you point out.
It really is, and some of the people now I've been treating for over 20 years, 25 years, so we know each other over a really long time, and I'm probably one of the few doctors that they have experience with who actually believes that they're ill and is concerned about that.
Yeah. So. And I think although there are no FDA approved treatments right now, you mentioned a few that you think are been helpful to some of your patients. Do you take that at a patient-by-patient basis, or are there standard treatments that you tend to use?
It's totally patient-by-patient. I try to determine if there's an infectious process and whether that's viral or bacterial or spirochete, and then go about options in terms of treatments for those things. Certainly the autonomic dysregulation piece is one that can really be helped. And now we're also kind of moving into understanding more about mast cell activation syndrome and how that might be an underlying manifestation that's contributing to chronic illness. And so now that's another area of exploration to really pursue. And we don't have great tests for that, but we do have a number of treatments that can be tried. And there's a number of good researchers out there who are contributing to more of a pool of information and treatments.
Thank you, Jeanne. Our next panelist is Michael Van Lker. I hope I did that right. He's a neuroscientist and ME/CFS research fellow at Mass General Hospital and Harvard Medical School, as well as an instructor at Tufts University. His research includes brain imaging to look for evidence of altered immune and metabolic function in people with ME/CFS. So we're fortunate to have a researcher here as well. Welcome, Michael. What current research are you conducting, and how do you see it translating to the ME/CFS patient population?
So, hi, everybody. So essentially, we have two studies going on right now. One is trying to characterize, specifically trying to characterize the neuroinflammatory component. So the term encephalomyelitis means inflammation of the brain and nervous system, and there's evidence for that, but it's not as direct as it could be with current techniques. So we're trying to use sort of modern techniques to validate some of the things that have been really reported for decades and decades. I mean, there have been historical outbreaks of this condition, scores of them, including sort of a famous one in London in a nurse's unit, and it was considered to be hysteria because it was a nurse's unit. And they, some of the patients who died, they ended up doing some sort of assays on spinal cord and found some evidence of an inflammatory process happening. And unfortunately, that line of research hasn't really been pursued as much as you might expect, largely due to the psychologization of this condition, and largely due probably to the fact that it's up to 6 times as common in women as it is in men. So we're trying to find evidence of neuroinflammation with a PET scan, positron emission tomography, where we can essentially, the nervous system's immune cells are called microglia, and we can tell whether those cells have been activated. And that's what we're trying to do. That's just at a resting state, so they just come in and lie there in the scanner. And a second study that we're doing is one in which we're trying to characterize this post-exertional malaise, which I think patients would tell you that that's really sort of the crux of the illness, is sort of a failure to recover or a profound reaction to exertion. And what we're doing is we're doing a baseline scan. This is just with fMRI, so no injection, it's just a strong magnet. But we're trying to characterize autonomic function at rest, just a baseline state. And then we do so again during their post-exertional crash. So they engage in an exercise test deliberately, and these are extraordinarily generous patients who deliberately crash themselves knowing that we can better understand the condition if we can see crashed versus not crashed. So they deliberately engage in an exercise test to allow us to scan them during this crash state when they're extra sick. And they can stay sick sometimes for a long time. It's really, we take it seriously. And the exercise itself, the exercise test itself, we're getting a huge amount of of information from that as well. It's called an invasive cardiopulmonary exercise test. So this is pedaling on a bicycle, and it's only about 6 to 8 minutes. It's considered sort of a moderate exercise test. But the resistance in the pedals, they pedal at about 60 hertz or so, and then the resistance increases about every minute until they can no longer keep that pace. And it is essentially exhausting, and we can get information from their exhaled breath, and also during the exercise test itself, there are indwelling arterial catheters. So there's a catheter in the pulmonary artery and one in the radial artery, so we can examine blood as it's leaving the lungs fully oxygenated and as it's entering the lungs fully deoxygenated. So for example, is it possible that, which we think is probably true, that these folks are not utilizing oxygen as efficiently as they might be. And then also during this exam, during this test on an ongoing basis, we can sample blood from those 2 points and see, as blood is filtered, we get sort of post-liver, post-filtered blood, and then pre-filtered with a lot of junk in it, we think probably, so we can test that as well. So those are the 2 studies we've got going on right now.
Thank you. Sounds like some very interesting and important work, Michael. Thank you. We're also studying neuroinflammation in our Gulf War illness veterans, so I think that's a very important thing, and it's important because there are treatments that can be utilized if we find that it's found in both of these populations. So I think that's very important. I think right now we'll open this up to the audience for questions for our panelists. Yes? If you want to just wait a moment, I think we have some students that have microphones, and we'll make sure everybody can hear you. Maybe just if you want to stand up and introduce yourself, please.
Hi, my name is Agathe. I'm alumni from BU School of Public Health. I got my MPH there. So I have a cousin who has this disease, and my question is there some sort of official diagnosis or a way for doctors to actually run tests and confirm this that the patient has this illness, or is it mainly based on the symptoms that the patient report? And going off of that, is it possible that there may be a misdiagnosis? Thank you.
Maybe Dr. Hubbuch. Yeah.
Right. Yes. So whenever you're looking at a patient with multiple symptoms, you have to try to figure out what's the diagnosis that fits most, that includes all the different symptoms and makes sense. So before diagnosing somebody with ME/CFS, you want to make sure they don't have something else that's treatable. So you have to be a good sleuth in terms of determining what's going on with someone. I mean, there's not like a set list of you go through 10 things and then you come up with a diagnosis. So I think that's one of the reasons that it is difficult to diagnose, because somebody has to think about it first. They have to understand the illness, and then they've got to look at the broad spectrum and rule other things out.
I can just add, if I might, that the CDC has now considered a 2-day exercise test to be diagnostic, but it's kind of tough because not everybody has the ability to, first of all, not every facility has the ability to run that 2-day VO2 max exercise test, and patients will crash if they do that. So, but yeah, I mean, it's misdiagnosed all the time. It's become a bit of a garbage bin diagnosis, unfortunately, partially because the name is not great. Everyone's felt fatigued, and it doesn't, as you see, it looks a lot more neurological. Some of you may not familiar with this condition coming in may have had expectations, and wow, that looks a lot more neurological than fatigue. But, for example, I get patients writing to me all the time, and this one young woman wrote to me and said, I used to be able to run 10 miles a day without any problem, and now when I run 8 miles, I feel a lot more tired than I used to, and my doctor told me I have ME/CFS, and no, you don't. I mean, that's not it. But unfortunately, even doctors really don't get taught about this condition in medical school, so it ends up a bit of a garbage bin diagnosis.
Yes, so she's saying that it's still by self-report as opposed to a blood test or some other test you're asking, yeah.
Yes, you would be paying attention to the report and then, really asking them, pointed questions. What happens when you go to the store? What happens if you walk 2 blocks? What happens if you have to stand for 10 minutes?
Next question, over here.
Hi, my name is Elizabeth Townsend, and I've had CFS for 30 years, plus or minus a few. And I continue to marvel at several things that don't come up in these conversations when I hear people talking about this. I mean, one of the key things for me in being here tonight was learning how to meditate with Jeanne Hubbuch. I mean, it was profound, and I don't hear people talking about that. The gastrointestinal problems, I had an acupuncturist who relieved most of those. So, it was kind of a step-by-step process. My doctor at MGH recommended hydrocortisone, which I was on for years and years, and totally changed my life, truly. I mean, I'm not cured. I don't want to pretend that happens. There was one other thing. As I turn to my husband, because I can't remember what the fourth. Oh, and so the exercise thing is really, really dicey. I'm so glad it's off the list now of you must do this graded exercise thing, because if you're lying in bed and you can't crawl to the bathroom, who's going to do graded exercise? But I will say that I did learn to walk down the driveway and then walk around the circle. And now I go to the pool and I do some pool work that has made me much stronger. And I just spent 2 weeks in Paris, walking around Paris. it doesn't mean it doesn't mean I won't go home and go to bed tonight and spend, where are you, and spend how many days in bed. You know, it's such a tricky thing. But my frustration is that the conversation isn't around some of the things that we can do ourselves. And it's not going to cure it. It won't cure it, but it might make your life just a little bit better.
Thank you for that comment and for mentioning some integrative therapies that we find helps with lots of different disorders. It's not going to cure the disorder, but it certainly can help sometimes. Thank you. Next question.
Yes. My name is Helen Barber, and I'm a neuroscientist. And I have a comment and a couple of questions. The comment is I was struck by the huge variability in this disease, which happens in other diseases as well. Some people they do so much in spite of the disease, and some people are completely comatose and in bed all the time. And my question is, when you study the vets from the Gulf War, have you been able to come up with some commonalities to see, because they have a lot of things in common, so if you see that if there is a higher prevalence, have you been able to come up with some features that may help us go on and understand this disease? And the other one is I would like to hear what happens with the hypothalamic axis, because that is really much closer to things that I understand.
Thank you, Dr. Barber, for coming and for asking that question. I'll take the one about the Gulf War veterans. And yes, it's a multi-symptom disorder, much like ME/CFS. It's not the same thing, but our Gulf War veterans also, some have ME/CFS as well. So they have fatigue, they have chronic pain, they have cognitive problems, a lot of the same issues. We are studying biomarkers of the disorder, so we're looking for things like neuroinflammation, like some of the ME/CFS researchers are doing as well, because we're trying to get at treatments that we know might be available for that, and we think that may be at the root of what's causing at least Gulf War illness, and perhaps maybe ME/CFS in some people as well. I hope that answered that part of it. Does somebody else want to take?
For the HPA axis story, so there is glucocorticoid resistance, so the dexamethasone suppression test is reduced in some, but not all. So essentially that means that the stress hormone cortisol normally acts on most cells of the body, and normally when you experience a stressor, you release cortisol and it comes back up and sort of turns the system off. And that's the reason that when you have something stressful happen in your life, you're not just producing cortisol for the rest of your life. And this system doesn't seem to work as well in some patients. Again, you're right that it's a messy diagnosis. So that's part of the reason that we like sort of within subjects designs, within subjects challenges. So an individual patient at baseline, and then after something happens to them, so we can try to understand how they respond, as opposed to comparing healthy people to people that have this condition, because a lot of times you're dealing with people that are also in bed or at least greatly reduced activity, which we don't think is the reason for the condition, but it certainly is a factor, and you have to try and tease that apart, and it's difficult to. So we're trying to use creative control groups in our case control studies, so the ones in which we compare patients to controls, so like mitochondrial disease as a control, first-degree relatives and housemates as a control, major depressive disorder even as a control.
Other questions? Right here. Then we'll come over here.
Actually, I have a comment more than a question. I'm a graduate of the BU School of Public Health. My daughter went to BU COM, and I have to say, shame on BU and how they treat these students that have chronic fatigue. They did not accommodate her. They would not let her go part-time. So I think BU needs to look at itself and do more to accommodate students who are trying to get their degree but cannot go full-time.
Thank you for that comment. Next question.
I had a question. I think it's really more for Jeanne Hubbuch. I used to see you years ago when you were taking Medicare, but my question is, I was treated for Lyme disease and my chronic fatigue got better, but the chemical sensitivity didn't. So I'm wondering, I'm in a water damaged building, and I'm wondering, do you know from your experience if mold is a contributor that, just like Lyme, to chronic fatigue or ME/CFS and chemical sensitivity?
100%. Mold is the creeping crud that can really make you sick. So if you're in a water-damaged building, you're going to be ill. And it can cause everything from brain fog to muscle pain to severe fatigue, sleep disturbances, can all be from mold. And, once you're already chemically sensitive and you put mold on top of it, then you become even more chemically sensitive and more intolerant to more things. So there are steps to detoxify from mold. The first thing is to get out of the mold-infested building, and then there are binders or chelators that can bind the mycotoxin and get it out of your system, and you excrete it through the feces.
Is there a way for me to get more information from you about if there's any way I can get treatment, because I don't know enough about your practice, because you don't take Medicare, and in terms of testing, because I was supposed to be tested for mold, and I was confused.
There is a test for mycotoxin that's a urine test that Medicare does cover, so I'd be happy to talk to you about that, or just contact me and I'll let you know how to get it.
Oh, okay, thank you.
Okay.
So maybe after the event I could ask you?
Yeah, actually, I'm not going to be here at the end of the event, so catch me right after this.
Okay.
Another question? Yes, in the front.
Hi, my question is actually for the caregivers. I'm with a group of future nurses, and we're wondering, as a caregiver, what could we do to help these patients? We can't diagnose them, I'm sure. I'm not like a neuroscientist. I'm not going to find the up-and-coming medications, but on a bedside manner, what I can do to help.
Well, I appreciate that question. As a caregiver and as a member of this association, we're always looking for healthy people to help. One of the problems about our organization is it has so many patients. Patients just can't do the stuff, and even like what Rivka's going through, and like she said, she doesn't know how that's going to impact her. My daughter just couldn't make it today. So I would say go to the website, and there's a volunteer list of items that we really need support with. And if there's anything that is up your alley, that would be a tremendous help. Thank you.
Thank you. We have a couple of folks here who are faculty members of BU as well. Susan, would you like to make any comments before we see the rest of the movie? Right in the front row, right here.
Hi, I'm Susan Kandarian. I've been at Boston University for 30 years. I've been sick for 22 years. And the last 6 years have been steadily getting worse. I guess the only thing that would be interesting for this audience is I guess I again want to emphasize the heterogeneity at how this disease presents. I was able to work full-time and have an active laboratory going for the first 10 years of the disease. And so everybody around me, my colleagues, nobody really even knew I was sick. And you can't really say it because they can't do anything. So it's very tricky. But I was one of the lucky people because I got sick right before my 37th birthday. So I had all those healthy years, which I'm very grateful for. And the first 10 years were what's considered mild. But what people didn't see in the workplace is that the 35 hours I was at home, I'm lucky enough to have a home very close to Boston University, and I was able to just walk home a mile and then get right in bed after that. So people saw me as a healthy person, but just to say, a lot of us look healthy, but you don't see what happens to us after you see us in public. And also the heterogeneity, last thing I'll say is a lot of people you saw on the slide have pain. A lot of people have muscle pain. I don't. I don't have any pain whatsoever. except that which you'd think of somebody who's 60 years old. But I do have the thing that everybody has with this disease. I'm pretty sure everybody has this, is that after mental or physical exertion, there is a malaise, and it's most similar, if you're well, I can explain to you that it's the most similar to what you have. I think everybody's had a flu of some kind. The worst throes of a flu, that's what it feels like. That's what this so-called post-exertional malaise is. It's like a flu malaise. And so all the other things that are associated with viral kinds of syndromes, that I'm pretty sure 100%, correct me if I'm wrong, of patients have that kind of feeling. So it's very difficult to think, it's very difficult to do a lot of things. And then all the other symptoms that people suffer have to do with, are just heterogeneous. We're all different in those other kinds of lists of symptoms that we all have. Thank everybody for coming, by the way. And I'm a muscle biologist, so if you have any questions about muscle biology, you can ask. And they are, just today it was announced that the Open Medicine Foundation, I think you'll see in the rest of the slide, I don't want to take any more time, is a really important foundation. And it's in California, and most of the work is started at Stanford. It's called the Open Medicine Foundation. My wife and I are major contributors to this foundation, and we hope to be even bigger contributors very soon. And they are doing outstanding work. They have many scientists that they're now funding. You know, many they've raised $14 million. But now some folks in Boston are now part of that foundation's funding mechanism, and Michael is one of the people who is part of the group of the Harvard Consortium, part of the Open Medicine Foundation that has recently been funded. They haven't told us the amounts. They did get $1.8 million. That was a while ago, but now it's been expanding, this new collaboration here on the East Coast. So that's really good news, because these folks at Open Medicine Foundation, the guy who started it with another woman, Ron Davis, he's a one of the most famous geneticists alive. He's an amazing mind. You'll see him.
Thank you, Susan.
Okay, thank you.
Appreciate you giving us all the helpful information. I think our last person is going to be Dr. Alan Gerwin, who is a retired child psychiatrist. Is that right? Please comment.
Thank you. My name is Dr. Alan Gerwin. I'm a child psychiatrist and an adult psychiatrist. I've treated a lot of children and adolescents with ME. Yes, children and teenagers do get it. The prevalence rate is probably less than is the case with adults, but actually there has been no really solid research on the frequency within children. So many of the aspects of the pediatric aspects of ME have just not been studied. When we worked with others to write a primer for pediatricians, the amount of information was very limited. But fortunately on the team we had a lot of pediatricians from around the world, and we put together what we knew and reached a kind of consensus. Children do have the illness. We know that it occurs at least after 10, and there are many who think it occurs before then. The onset is usually slower than in adults. Adults mostly get an acute start of their illness. Children have a better prognosis than adults. No one knows why, but there certainly is an important aspect there that needs to be closely studied. Also on examination, physical exam, children tend to have more signs, actually signs that are significant in terms of making the diagnosis. I'm sorry to say that pediatricians are among those least knowledgeable about ME, and it's going to take a lot of work to convince them that they need to learn, and learn quickly. One other aspect, while the prognosis is better in children, there's something that is a major problem. It's the major cause of prolonged school absence, and it makes a very big difference. So that a strong part of the treatment is enabling them to go to school or study at home and to keep them up with their peers as much as possible. Unless there are other questions, and I'd be glad to answer them, that's a very quick synopsis.
I think that Pat might have had a question in the back.
Pat? Yep, okay. We'll take Pat. Okay, and then I'll wrap it up.
I'm a nurse, so to respond to your question, and also for, you know, whether there are students, I think there are a few from physical therapy, and I don't know whether there are some students from occupational therapy. But I think for many of these patients, and at least in terms of what I'm seeing with my daughter, they're isolated, they are so alone, they've lost almost every aspect of their life, and they need support. I know when she was hospitalized, she was teaching all the nurses about what ME was. Nobody heard it. Or when she's been in the emergency room, it's the same thing. The one thing that you've heard a lot about is that energy envelope, and you know, my daughter would say, no, we don't need somebody to teach me, but I think it's something to think about in terms of having a coach, somebody who knows about energy conservation and can help guide them in terms of looking at ways to preserve energy. You know, I did that a lot with my cardiac patients, but I think the same thing applies. And you know, when Erin needed a wheelchair, she was looking at Unrest and seeing what wheelchair Jen had, you know, and I contacted people that I work in terms with physical therapy and what kind of a wheelchair would be the best kind. You know, somebody can't propel themselves, so they need some kind of electric wheelchair. What kind of a shower chair do you need in the shower? You know, things like that. They're really, you know, learning how to, you know, if you can cook at the stove, putting a chair there to stir food. So I think that those are really, you know, concrete things that maybe some of these other disciplines can start thinking about in terms of providing resources for patients and helping them.
Thank you, Pat. I think with that, we're going to move on to the movie. I'm very happy to have been invited here, and I want to tell you that coming up, you're going to see a pioneering immunologist who has worked with MECFS for many years, Dr. Nancy Klimas, and she actually got me involved in being involved with this group as well. So, thank you.
I want to thank Dr. Sullivan and Jeanne Hubbuch, Michael Van and Bob Robitaille for the wonderful conversation we just had. We're going to see the rest of the film now. It's 70 minutes. We hope that you can stay. It's very powerful, and it ends in an exciting note. Patients, people with ME around the globe are now organizing what we call Millions Missing demonstrations around the globe. We will bring empty shoes from people who are stuck in bed and unable to leave their homes, and we display acres of empty shoes for people to get a visual of the millions of people who are missing from their own lives because of this disease, the millions of dollars that are missing in research funding, and the millions of doctors who are missing out in education. Not just doctors, any healthcare professionals who are missing out on the education. About the disease. A couple of things. We're circulating a sign-up sheet. This is so that you can sign up for our newsletter as well. So we're a state organization. The Massachusetts ME, CFS, and FM Association is a state organization. You can also sign up for ME Action. That's a national advocacy group, and they're the ones that are putting on the Millions Missing demonstrations with the help of local organizations like us. And then also you can sign up for the Unrest newsletter. Can I just see, are the clipboards anywhere? Where are the clipboards? Okay, can you be sure to send them around. We have a few save the dates I just want to tell people about. We have the first Unrest screening will be happening in New Hampshire at Dartmouth Hitchcock Medical Center, also at the Geisel School of Medicine. Also, the Northeastern University School Health Academy is holding an event for nurses, school nurses and teachers, October 30th. in Burlington, and we, our state organization, have our annual meeting, and that will include journalist David Tuller. Investigative journalist David Tuller used to write a lot for the New York Times. He still does write for the New York Times and Stat Magazine, Stat Online website, and other health-oriented publications. David Tuller has led the effort to discredit the largest study ever conducted for ME/CFS. Why would someone want to discredit the largest study ever conducted for ME/CFS? Because methodologically, it was poorly organized, and they changed the outcome measures midway through the study, and the end result was that they postulated that 2 treatments are the best treatments for people with ME/CFS, and the patients said no. Exercise does not help us, it can hurt us. So the study said graded exercise was the best treatment. It's just not true. So David Tuller, investigative journalist, world-renowned, is tackling this, what's called the PACE trial, to show it for what it really is. And we hope that you can come. Also, please contact us. We're at massmecfs.org. All these events in the Save the Dates are on that website. Call us if you want to volunteer. We very much need healthy volunteers, and even if you're sick and homebound, we can still use you as a volunteer. We would love it. Call us to ask, or email us to ask questions, or we can bring this film to your organization. Also, outside, we have handouts. Handouts are for normal fact sheets for anybody, and also there's specific handouts for clinicians and researchers. And with that, I hope that you will enjoy the rest of the movie. Thank you all so, so much for coming. Please contact us if you have any questions at all. Tom, if you're up there, please feel free to roll the film. Thank you, everybody.